of targeted therapies in Oligo-Metastatic Disease. And this will be given by Dr. Ticiana Leal, who is an associate professor at the University of Wisconsin. So Dr. Leal, I'll turn it over to you for the talk.
Thank you. Thank you, everyone. Thank you for being here today. My talk will be on targeted therapies in Oligo-Metastatic Disease. These are my disclosures. And the objectives of today's talk will be to talk about the use of targeted therapy in patients who have non-small cell lung cancer with Oligo-Metastatic disease with a driver mutation. And really here I'll focus on the use of combining targeted therapy with local ablative therapy such as mainly radiation, and how we can use this in clinical practice based on the data that we have at initial diagnosis, and then in the setting of progression with resistance, and also in the setting of Oligo-Metastatic disease with CNS involvement or brain metastasis. And so let's define Oligo-Metastatic disease. So Oligo-Metastatic disease occurs in about 25% of patients who have advanced non-small cell lung cancer. And we think about Oligo-Metastatic disease as sort of being a different kind of disease with perhaps different biologic behavior. And one of the things that's been difficult in terms of thinking about Oligo-Metastatic disease and using therapies for this kind of presentation is the fact that there have been different ways of defining it. Most recently, though, the European organization created a statement to try to unify this definition of Oligo-Metastatic disease and defined it as a maximum number of metastatic lesions as 5 and involving 3 organs, and identifying this using PET scan and brain MRI, since this can also occur in the brain. And mainly another important definition of Oligo-Metastatic disease is that all lesions, both the primary site as well as the sites of spread or the metastatic lesions, should be amenable to radical intent treatment with acceptable toxicity. One important thing about thinking about Oligo-Metastatic disease is, why is there a rationale for using local therapies such as surgery and radiation? And one of the thoughts are that progression most frequently occurs in sites of the original disease, and the treatment may also prevent further dissemination of disease by getting rid of some of the resistant clones, especially with regards to targeted therapies and driver mutation patients. So here's some of the prior studies that have evaluated the use of SBRT or radiation that is used at high doses that can be delivered very effectively in patients with Oligo-Metastatic disease. So we had lots of sort of retrospective studies that looked back and sort of identified that perhaps using local ablative therapy such as radiation really seemed to lead to benefit for patients with Oligo-Metastatic non-small cell lung cancer. And here I'm highlighting 3 studies, and these studies actually used treatment with radiation in different settings. The first one is the PALMA study that looked at radiation for patients with Oligo-Metastatic cancer. This study actually included multiple different kinds of cancers, including breast, prostate, and lung. But really what they did here was they actually delivered local ablative therapy, in this case radiation, in combination with systemic therapies, and really found that this led to improved survival for patients when they added the radiation. The second study here is the Iyengar study, which also looked at addition of radiation for patients with Oligo-Metastatic disease. But now what they did was, first patients got the systemic treatment, then they went on to either receive systemic treatment plus radiation or systemic treatment alone, and saw that in this setting, we call that consolidation, patients had improved outcomes with better control of their disease with improved progression-free survival. And then the last study is the Gomez study, which also looked at consolidation therapy. Patients received treatment with systemic therapy, and then after good disease control, after 3 months of frontline therapy, they were then randomized to receive their systemic treatment or the systemic treatment plus the consolidation therapy with radiation. And here they also saw improved progression-free survival as well as improved overall survival, really setting the stage that there are subsets of patients who seem to benefit from these local ablative therapies. As you can see here in this slide, though, the definition of Oligo-Metastatic disease is different between these studies. What about in patients with driver mutation? And here, again, I think similar to what others have said, a lot of the data that we have that is more advanced in development is really in the EGFR population. So just for the purposes of talking about how we use these therapies in driver mutations, we'll highlight the studies in EGFR patients. In retrospective studies, we saw that the addition of local ablative therapies such as radiation in patients with EGFR mutations really led to improved outcomes. And now we have the interim report of the first study in a sort of prospective fashion of randomized phase 3 study that really looked at patients with EGFR and incorporated the use of radiation. And this is called the CINDA study that I will outline in the next few slides. So here's the study design of the CINDA study. And this study enrolled patients with advanced non-small cell lung cancer with EGFR mutations and then randomized them to 2 arms. The standard of care, which would be the TKI, such as gefitinib or erlotinib, which are first-generation TKIs, or the combination of the TKI with stereotactic body radiation or the high-dose, really pinpoint radiation. And then the primary endpoint of this study was progression-free survival, as well as overall survival and safety. And this was the first study that in sort of a prospective, randomized fashion, really demonstrated that the use of TKI, such as erlotinib and gefitinib plus radiation, led to improved outcomes for patients with oligometastatic non-small cell lung cancer. And here we saw an improvement in progression-free survival, and this was 20 months versus 12.5 months. And then we also saw an improvement in overall survival, which was 25 months versus 17 months. So really showing that there is a subset of patients that really do seem to derive benefit from the addition of upfront radiation plus their TKI. A few points to highlight, though, is that there was a very high screen failure rate. It means they had to look at a lot of patients before they really identified patients that would be eligible for this study. And the screen failure rate was about 78%, which really shows that really it's a small subset of patients who would potentially be eligible for this sort of strategy. The other thing that I'd like to highlight in this study is that they excluded patients with brain mets. So, we know that patients with Oligo-Metastatic disease, some of the sites that can be present is the brain. So I think that's also something that we need to think about. And then lastly, they did include patients with EGFR mutations such as exon 20, and there was a higher rate of these patients in the TKI only, and we know that first-line EGFR TKIs such as erlotinib and gefitinib really don't work for the EGFR exon 20. But nonetheless, I think this is a meaningful study and is the first positive study at this interim analysis, and we're hoping to see more of the results as the study matures. In terms of safety, overall, this strategy with the addition of radiation to the TKI was demonstrated to be safe, and there was no significant difference in toxicities such as pneumonitis or inflammation of the lungs and esophagitis or inflammation of the food pipe with the addition of radiation, which of course is of concern when you're adding therapies together. So moving on, thinking about how do we apply this to what we do today? Well, in patients with EGFR mutations that are sensitizing in the front line or as their first treatment, we generally use osimertinib. And as I said in the prior study, the CINDA study, they really used erlotinib or gefitinib. Now we have seen some data looking at the use of osimertinib and then using local ablative therapies after, like a consolidation approach, showing that there is benefit here. This study is still kind of retrospective, not prospective, but also showing a signal here that there is a group of patients with EGFR mutation who seem to benefit from consolidation radiation after osimertinib and having a response. So let's talk about the use of targeted therapies in the setting of oligometastatic progression. We know that patients with driver mutation positive non-small cell lung cancer that are treated with targeted therapies, they can experience progression at limited sites. And treating with ablative therapies such as surgery and radiation seem to be effective before the widespread dissemination of the resistant clone. And that way you can continue the targeted therapy and hopefully have disease control for a longer period of time. And we also think that there might be ongoing benefit from the targeted therapy at the other sites of disease that are not progressing, because you can continue to suppress the sensitive clones that have not yet acquired resistance. And so here are some of the studies that have looked at that. And this study actually included patients with both EGFR and ALK, showing that if patients have limited sites of progression or oligoprogressive disease, that you can radiate the sites of progression and then hopefully continue to use the relevant TKI. In this study here, this was crizotinib or erlotinib for ALK and EGFR respectively. And so here's another study, again, showing that you can radiate the sites of progression using local ablative therapy such as radiation, and showing that local therapy followed by continued treatment, in this case with an EGFR TKI, was well tolerated and led to improved progression-free survival as well as overall survival. And this is something that is actually done in clinical practice. I'm showing you here the NCCN guidelines, and specifically for osimertinib in the NCCN guidelines, as you can see here, for patients who have limited sites of progression, as you can see at the top, you can consider definitive local therapy such as radiation or surgery for limited lesions and then continue osimertinib. And similarly, we'll talk a little bit about the brain, but if there is oligometastatic progression in the brain only, you can consider definitive local therapies such as stereotactic radiation or sort of very high level radiation to the brain lesions for these limited lesions, and then you can continue on osimertinib. So here are some of the studies that have been looked at that, looking at targeted therapy in the setting of oligometastatic disease with progression with predominant disease in the brain. This study looked at the first generation EGFR TKIs. And here you can see here the sequence that patients received gefitinib and then went on to receive either stereotactic brain radiation, which is the more localized high dose radiation, or whole brain radiation, and then were able to continue on in sequence with their EGFR TKIs after. The response rate here was 41% with good disease control rate of 76%. So again, here showing that if you can radiate the site of progression in the brain, get good local control, there is favorable progression-free survival as well as overall survival, and patients can then continue on with their targeted therapy. So in conclusion, there is a well-defined subset of patients with oligometastatic non-small cell lung cancer that have driver mutation, such as EGFR, that do derive benefit from local ablative therapies up front, along with their targeted therapy. Now, I think this is evolving, and we really need to define better who are the oligometastatic patients that will benefit from this approach. And I think further studies in the phase 3 setting are warranted and are ongoing. And then how can we kind of extrapolate this to other patients that have different mutations, because some of these mutations are rare. And so I think that'll be important to know in the future. One additional important question is the optimal timing of these local ablative therapies for patients with oligometastatic disease. Some of these studies use combination therapy up front with radiation, and some of these studies have used first the targeted therapy and then using consolidation radiation. And I think both of these strategies are promising, but I do think we need further studies to better define which is the best approach and which approach is best for patients with oligometastatic disease up front and driver mutation. And then lastly, the strategy of adding local ablative therapy for patients who have limited sites of progression definitely leads to improved progression-free survival, local control, and may allow for continuation of targeted therapy in a strategy that we use in clinical practice currently. Thank you very much.
Thank you, Dr. Leal, for a great overview. Very complicated topic, and one with more questions, I think, than answers.